This conference will now be recorded.
All right, folks. So very good. I'm glad that you're all here. And I don't know why that came up. I guess because all right. So I'm going to be, we're going to we'll take a break like an hour into the lecture tonight. And I'm going to, actually, let me just go to it right now. And I just want to get some feedback from you, please, as far as if you can hear the video. Okay. So let me just go to one of my videos. Tell me if you have a problem hearing the video, hearing the audio. All right, so here we have the digestive system, a portion of it. We're looking at the small intestines and the large intestines. So let's take a look at, we already saw the. So, all right, so are you okay? We good? Excellent, very good. So when we take a break and such, I'm going to play a video for you in the break. Very good. Thank you, guys. I appreciate it. So what we're going to do is I will play this video for you here regarding fecal transplants. I think you'll find it very interesting. And so I'll put that during the break between me lecturing and go from there. All right. And so let's see here. All right. And then what I'm going to do is I think someone's on the phone. So, let's see. Okay, someone was on the phone. All right. When you're on the phone, I just have to mute you. This way, just I don't get the feedback and such. All right, let me hide everyone, share my screen, go from here. Good. All right, folks, let's go into our discussion tonight, which will be on the digestive system. And what I'm going to do first is I'll just show you, I'm going to be showing you images from the PowerPoint, but primarily it's going to be from my note packet that I posted for you all regarding the digestive system. So as we're looking here and seeing this image and you're seeing the digestive system with the organs that are contributing to the digestive system as well as being part of the digestive system. You'll notice that really, honestly, folks, it's one tube. It's a tube. Now the tube can be larger or smaller, right? The lumen, the inside of that tube, right, can be larger or smaller depending upon where you're at in this digestive system. There's other terms that we'll use for it. We'll call it the alimentary canal, the digestive system, the digestive tract. But you'll see here that there's tubes. It's just a system of areas, spaces, tubes that go from the oral cavity to the anus, right? And so this is what we want you to think about, is that understanding that it's a tube and that just different processes are taking place in the tube depending upon where you're at. And so that's the key and the issue here as far as and the challenge as far as understanding the digestive system and realizing that, again, it's quite phenomenal in that we are able to take plant and animal food products, process them through the digestive system, and as a result of that processing and then absorb those nutrients, be able to what? Take those and use them as building blocks in order to synthesize human parts, human cells. So we take animal, plant cells, we process them, we create human cells out of those. And really, the whole statement as far as you are what you eat, truly, if the quality of the nutrients that we take in, key important as far as how we're able to maintain our health and such. So let's go here and take a look at the digestive notes here. And so again, term there, alimentary canal, so the mouth, the pharynx, the throat, the esophagus, the stomach, the small and large intestines, these all represent this canal that begins from the oral cavity to the anus. You'll see here as far as accessory structures, right? And so know that the teeth, the tongue, the gallbladder, the digestive glands, as far as salivary, the liver, the pancreas, these are all contributing to what's taking place within the digestive tract and the substances that we take in and as they're processed. So when the substances are present, the food material, so in the oral cavity, right, we'll have saliva, we'll have mucus, and we'll have the food material. All of this being masticated, chewed, right, will eventually become what's called the bolus. The bolus is that combination of those. There's liquid lingual lipase. There's also amylase, right, for salivary amylase for carbohydrates, lipase for fats, and as well as, like I said, the saliva and a mucus and the food material. So that all comes together. We call it the bolus. The bolus enters into the esophagus, enters into then the stomach, and within the stomach and the mixture of the acids that are present within the stomach and the bolus, we create what's called the chyme, right? So the chyme will then end up being brought into the beginning of the small intestines, which would be the duodenum, and there's going to be secretions that are going to be added to it right in through the duodenum. The duodenum is where we have primary digestion taking place. Yes, the beginning of the digestion of fats, of primarily carbohydrates in the oral cavity. The beginning of and digestion of proteins takes place in the stomach, but then really the primary digestion of all of these and where enzymes are going to be coming from the pancreas, as well as secretions from the liver, will contribute to the digestion and breakdown, and then eventual absorption in the remaining of the small intestine as far as the jejunum and the ileum. Okay. All right, so let's move out of here. Let's go back to the notes. And we'll see here as far as, so this is, so I tried to do the best I could with this. It took quite a bit of time to put this together. This is a note packet that I continually work with each semester and try and tweak a little bit. What you'll see here is that the ingestion, propulsion, mechanical breakdown, digestion, absorption, defecation, you know, when you know these terms, know what they represent and what they mean and such, okay? Very important as far as understanding what's going on and taking place within the digestive system. Excuse me one moment, just gotta take a little sip. All right, so you'll see here this term, peristalsis and segmentation. Okay, so this propulsion, this movement of material, and really what we really want to happen is that we want from proximal to distal, we want to keep on moving it further deeper within the digestive tract, right? So this movement of food, peristalsis and peristaltic activity, deals with smooth muscle contractions. Adjacent segments of the alimentary tract organs will contract and relax, and continually moving it distally. Segmentation, also there's the movement that's taking place, but really it's kind of a mechanical breakdown. Now, understand that when we ingest food and we have our teeth are able to masticate it. They're able to chew the material. And what we're trying to do is really take material that we take into our body as far as foodstuffs and make sure that they're broken down into very small particles in order to make it easier for our digestive system to have the enzymes break them down and make them available for absorption. Okay, so you'll see here as far as this segmentation, mixing, and slow propulsion occur. So there is movement as well as this mechanical breakdown and such. Terms here as far as the peritoneum. So think of the peritoneum, really, it's the abdominal pelvic cavity is protected and covered in this covering, this peritoneal covering, this serous membrane that has two layers to it, right? And in the middle layer, between the layers, there's a little bit of serous fluid, allowing for movement and allowing for no friction to build up as a result of movement, very similar to other serous coverings throughout the body, okay? The cavity is and the cavity as far as between the visceral and parietal, so visceral peritoneum has direct contact with the viscera, right? And again, like I said here, contains that serous fluid. And then we have here as far as the mesentery, okay? So the mesentery, we'll look a little bit later and see some images and such, but you'll see that it kind of looks like an apron over the large and small intestines, okay? Extending from the stomach and such, the greater curvature of the stomach. And so we'll take a look at that. Provides a route for blood vessels, lymphatics, and nerves to reach the digestive viscera. Helps to keep everything in place and tightly in place, and helps also to store fat. And unfortunately, right, this is an area that can be very common to store excess adipose tissue. Okay, I'm going to turn my mic off for a moment. I'm sorry, guys, being in a place that's not my home. I'm going to turn on a fan also. I do apologize. I get kind of jacked up as I'm teaching, and so give me one moment. I thank you for your patience. Okay, thanks for your patience. I appreciate that. And so how about this also? Know that this is very important to for the peritoneal cavity. Uh, when we're thinking of the peritoneum and not the cavity as far as between the serous membranes, but actually the within the covering of the peritoneum, we have these organs present, right? Whether they're inside or outside. And you'll see here as far as so intraperitoneal, within the peritoneum, or outside of it, posterior to it, so retroperitoneal. So think of like the kidneys, they would be retroperitoneal. But within the peritoneum, we can actually put a substance, right, a liquid that can help patients who want to do, and let's show you an image of this, right? So, yeah, dialysis from home. If their kidneys are not, yeah, here we go, right there. And we call it an exchange, okay? So let's look at images here. So here would be, you're looking at an example of what's going on as far as a patient that is actually doing this. Here we go. So let's make this a little bit bigger. Let's see if this one's bigger. Okay, here we go. All right, so what's going on is that we have this dialysate, right, inserted into the peritoneal space, okay? And so you'll see here, so here's within the peritoneal cavity, right? And so with the organs that comprise the peritoneum, and again, there's a lot of vasculature present there, right? So we have this dialysate that will then create an exchange over an extended period of time, between 6 and 8 hours. And so what will happen is that when the patient wakes up, so the dialysate with waste products drain from the peritoneal space. So it's taken that period of time to have this exchange take place between the blood vessels and this liquid, right? Then we're going to drain the liquid out. And then this way will be one way to actually provide a means for removal of waste products from the blood when you can't do it as far as the kidneys are no longer functioning and doing that procedure. So peritoneal dialysis can be an option for folks that is a very good option instead of having to go 3 times a week or whatever it may be and it takes quite a few hours in order to be hooked up to the machine in order to have dialysis take place and the filtration of your blood and such. So just one option there. So minimize that. Okay, so let's move on to, let's see here, as far as the structures, and I'm going to go now to the PowerPoint and show an image for you here, as far as the basic structure of the alimentary canal, right? From the inner portion of the mucosa to the serosa. So let's take a look here and see. All right, so we'll see here that, folks. So the mucosal layer, this would be the inner layer, right? The mucosal layer. Then we have here as far as the submucosa, which would be this layer right here, and the muscularis layer, okay? And then that outer layer would be the serosa, okay? So there's multiple layers present, and different things are going to take place within the digestive tract, right? Depending upon where you're at. But this is just giving you an example of the different layers that are present within the alimentary canal, okay? So let's look here and just see as far as that inner layer, that mucosal layer. So when we think of the digestive tract, understand that mucus plays an important role, okay? So mucin is a protein with water creates mucus, right? So, and goblet cells are producing mucus. And know that they're very important, and there are different types of mucus also, know that. Very important for the digestive tract so that we don't end up damaging the tissues of the digestive tract, that mucus can be present. So secretions, mucus, digestive enzymes, hormones can be released in the mucosa. Absorption can take place, absolutely, right? End products of the digestion into the blood, most definitely. So our vascularity going to be very close to and present within the mucosa, as well as the other layers, absolutely. Protection as far as against infectious disease. And then we have, so that's the mucosa, because what's going on there is that that's having direct contact with whatever it is that we've taken into the digestive tract, right? depending upon where you're at as far as the esophagus, stomach, intestines, and so on. You'll see here as far as submucosa, that's the next layer. So there's nerves present there, right? Elastic fibers enable the stomach to regain its normal shape. So no, again, depending upon where you're at in the tract, in the alimentary canal, can really affect as far as function and such. Know that the muscularis layer, right? That's that next layer prior to getting to the very outer layer. And you'll see here as far as we call it the serosa. Now understand that in the esophagus, it's called the adventitia, that outer layer, okay? And again, let's just another look here and just seeing that multiple layers, right? And you're seeing there, and you can look at other images online and such also, that'll just show you more vascularity, because this isn't really showing you a whole lot of vascularity and such, okay? Now, let's see here, as far as like nerve innervation and such, so we already know that. So when we're thinking of sympathetic and parasympathetic, as far as the components of the autonomic nervous system, as well as the enteric nervous system. So the enteric nervous system kind of works a little bit like independently of the nervous system, as far as really focusing on what's taking place as far as the digestive system is concerned. But parasympathetic also very important as far as its stimulatory effect. Recall we talked about SLUDD, right? SLUD. We talked about rest and digest. These are all parasympathetic functions, stimulatory for the digestive tract. As far as I mentioned to you, the bolus already, right? So the mouth, the tongue, salivary glands, the teeth, right? This is all present within the oral cavity, and these are all working to work with the food that we take in and break it down and begin the stages of digestive processes. Now, know this and understand this, that really when you think about digestion, where does it really begin? Yeah, so we can say from an anatomical point of view, we can say, yeah, absolutely, the oral cavity. But how about when we think about it a little bit more, does digestion really begin in the brain? Because as we look at foods, as we just look at foods and smell foods, right? Don't even have to taste them just yet. We start to, just by looking at them, start the digestive processes and have secretions being secreted within the oral cavity. You salivate, right? When you're looking at food and you haven't even eaten it yet, and you're like, oh, that looks really good, and so on. So yeah, so digestion really, as far as anatomically, yeah, the oral cavity, but really begins in the brain. Look here as far as the tongue is concerned, and we talked about these before. I'm just going to show them to you again as far as know that primarily. There you go, Norma. Sounds good. Save a little bit for us. So the filiform papillae, recall that it's kind of like having that terry cloth towel or washcloth, right? So it's got all those little fibers there present. The filiform papillae, they cover the tongue, but they have no taste buds, so they're not involved in your sense of taste, okay? But they do give the tongue roughness, right? And provide that friction so that you're not just taking food in and it goes right down into your esophagus real quickly, right? Providing that texture, okay? Then we have the fungiform, the valate, aka also known as the circumvallate, and the foliate papillae. So let's take a look again at that image there in your PowerPoint. Oh, no, I don't. I have it here. Here we go. So here's just an image of the papillae of the tongue. And you're just seeing here that primarily it's covered in the filiform, okay? The fungiform look kind of almost like little mushrooms, okay? Hence the term fungiform. And you'll see here as far as these valate, there's circumvallate, the valate, they create a V. So that's pretty easy to remember that as far as the valate, create a V. And then the lingual tonsil, you'll see, not the lingual tonsil, that's right here at the base of the tongue. The foliate papillae are kind of like these little ridges at the posterior lateral aspect of your tongue. And then we're also viewing here the palatine tonsil. When a patient states to you, you know, my tonsils, when I look inside, they seem kind of swollen, they're talking about the palatine tonsils, right? Pharyngeal tonsils, again, we're talking about those tonsils at the superior aspect of and superior aspect of the nasopharynx and the posterior aspect of the nasal cavity and such, your adenoids. is what a patient might say to you. And again, here's the lingual tonsil. Okay, let's go back here. And then we'll go to salivary glands also. Let's see here. That's number 14. We'll come back to the dentition in just a moment. And so what we're looking at here, folks, is that we can see the pairs of salivary glands as far as we have here the parotid gland with its parotid duct. We have here sublingual, right? So sublingual would be what? Below the tongue. Submandibular, right? So here the mandible has been removed, and we can see that that's where the submandibular gland would be. And so these are all involved in contributing and producing saliva with mucus, okay? That'll enter into the oral cavity and contribute to the bolus, okay? That material of food, saliva, enzymes, mucus, the bolus, okay? So what does saliva do? And really, I know that it's very important, and the production of saliva can be inhibited by the sympathetic nervous system response, right? You can get kind of like a dry mouth. If you're stressed out and you're going to go for an interview for a job, right? It's going to inhibit salivary production. Again, parasympathetic innervation contributes to more saliva being produced because it contributes to the whole process of digestion. So it cleanses, it dissolves, moistens, and it's involved in also the enzymes that are present within the saliva. Again, like I said, lingual lipase and amylase can break down starchy foods and begin the process of breaking down some of the fats, okay? You'll see here as far as we talked about those different glands that are present. And you'll see here that serous or mucus cells, so mucus will produce, the mucus is going to produce mucus, right? But know that when we're saying a mucus producing gland, we'll use the term, we'll spell it as OUS instead of US. When we're talking about mucus itself, US. When we're talking about a mucus producing gland, it's OUS. You'll see here as far as the serous portion, it's a watery secretion. So the parotids and the submandibular, serous secretions primarily. It's the sublingual below the tongue that contributes more of a mucus type secretion there, okay? And know that as far as having a viral infection, as far as the myxovirus, this can cause an inflammation, a very severe inflammation of your parotid glands. And this can be really make a patient quite sick. And again, too, there's vaccines and such that are at present, but there are people that choose not to get certain vaccines and such, or any vaccines at all. And so then this is why we still have this, that's comes out, and patients will suffer from it and possibly give it to patients who have a, I won't go on. Just stop that. All right, composition of saliva. So let's think about saliva. So vaccines and such, we all have to make our own conscious, educated, decisions regarding vaccines and such. And so my wife and I, so she's getting her second vaccine for the COVID. I had received both, 2 vaccines for it. I know it's not an easy thing, folks, and it's not, can be a little stressful thinking about it. We had the Moderna one, and it's a little bit stressful, but you know what? You just have to make the decision where, what do you want to do with your life, and what do you want to do as far as, making sure that you can protect yourself as best as possible. Nothing's perfect, any type of, know this also, just give you this, then we'll move on. Anything that we do as far as in medicine is concerned, right? No matter what it is, chiropractic included, because yes, can people get hurt via chiropractic adjustment? That happens. Because if the clinician is not doing what they should do properly and not making the correct diagnosis, as well as, making sure that they're doing a proper exam, and folks, things happen. And as a result, right, know that it doesn't matter what it is that we do, whether it's a vaccine that we take, whether it's a pill that we're taking, whether it's an over-the-counter medicine that we're taking, all come with a risk. Yeah, thank you for sharing that, Ruth. Yeah, Indeed, you just have to try and do the best you can as far as decisions for you and your family and such. And so I would tell you that be educated. Don't just um, do things just because, but do things because you've looked into it and you feel that this is safe and you can do the best that you possibly can for you and your family. So you'll see here that really primarily saliva, it's primarily water, right? And it has a little bit of more of an acidic part to it as far as the pH is concerned. Remember, 7 is neutral, so 6.75, very slightly acidic. Okay. Also, remember too that when we talked about the immune system and such, so remember that the IgA antibodies, they're present in the secretions, and lysozyme is also present, also working as far as in defensins, working to provide some type of defense as well as your tonsils being present. And know that having saliva present, very important as far as having not a dry mouth, as far as the contributing to your oral health. And so sometimes as a result of medications, as a result of patients involved in certain activities that stimulate sympathetic stimulation, they need to then do things as far as there are washes or rinses and different things that can contribute to the moisture present within your oral cavity. Okay. As far as dentition is concerned, right? So the teeth are concerned, and again, I posted a video regarding this for you all, but you'll see here, let's go into the PowerPoint for a moment. And so first we'll look at this image here, and then we'll move to another image. But here you're seeing the dentition of an adult, okay? And you're seeing here also the uvula, the hard and soft palate, and you're seeing here as far as the palatine tonsils. So the adenoids, if we were to remove the palate, they'd be up in about this region right here as far as the pharyngeal tonsil. And then you're looking at here as far as the gums are concerned. And so these teeth, as far as for the mandible and for the maxilla, they are all, they're present within both of those bones, and they're in the alveolar processes, right? We call those the alveolar processes. You remember that from A&P1. And you'll see here as far as, so if we were to just take 1/2, right? So to be looking at 2 incisors, 1 canine, 2 premolars, and then 3 molars. Okay. Now let's take a look here and see as far as, so now here you're seeing the same thing as far as the breakdown and such. And so this is just giving you an idea as far as what we're looking at as far as the teeth. And so let's take a look at one of the molars and see that we have here, here's the crown, here would be the neck, here would be the root. Let's take a look at our notes and just see what we put down here as far as, so the crown, the neck, the root, right? And if we were to look at and I showed you a cross section of a tooth, and you can see this in lab, and I absolutely recommend, like I said, when you're in lab, focus on touching the models. Focus on thinking about the word, the term, and looking at the model, saying it out loud. Very important for you all to do that, folks, okay? Know that we have, so 32 for the permanent presentation of the teeth as far as dentition, and for baby teeth, the deciduous teeth, 20. You should know those numbers. You should also see here as far as then the enamel is the very hardest substance in the body, outer covering of the tooth. Then we have the next layer would be the dentin and the pulp and the root canal. And this is something that's not so much fun as far as that. If you've ever experienced a root canal, I have, and it's never any fun. And hopefully they work out well. And if they don't, then you have to do all kinds of other fun stuff that's not so fun. Yeah, thank you, Norma. I would agree, they're terrible. Now, as far as the pharynx is concerned, so when we think of the pharynx, think your throat. And I showed you in lab this past week and the week before that there are 3 areas to it, the naso, oral, and laryngopharynx. And again, common pathways for food and air. Then what will happen is that we have that epiglottis that will prevent any food and liquid from entering into the respiratory system, and then only air will pass through both ways as far as for our ability to speak, as well as far as also our ability to take in air as far as the trachea is concerned into the respiratory pathway there. So let's take a look at an image here. And so here I provided for you an image to just see. So here we would have the nasopharynx, the oropharynx, and the laryngopharynx. Okay. And so you're looking at, the spaces in through in here. So usually like through in here, oro, laryngeo, naso. And this is the opening for the eustachian tube right there. And this is right, that spot right there. Okay, let's go back into the notes. As far as the esophagus is concerned, right? So I mentioned to you in the lab, and I showed you as far as with the stomach is concerned, we have a cardiac region and we have a pyloric region. So at that cardiac region, this is where the esophagus will interact with and bring food, bring the bolus to the stomach in the cardiac region. Also known as, aka also known as the gastroesophageal sphincter. Okay. Mucus cells on both sides of the sphincter help protect the esophagus from acid reflux. We can have different types of issues going on where there is reflux that can take place over an extended period of time and actually change the cells, and we call this Barrett's esophagus. And this is something that there is a possibility that could lead to cancer. There's some different theories regarding it and different research saying, well, maybe not, but there are instances where it does. So just so that you know that there. So really, any type of reflux is not a very good thing. The acids should stay in the stomach and not should come regurgitating and refluxing back into the esophagus. And if anybody, we've all experienced heartburn at some time, I'm sure, but to have it on a chronic basis, it's never a fun thing. And hiatal hernia is something very interesting also, as far as the ability for the stomach, the superior aspect of the stomach, the cardiac region, to actually herniate through and up above the diaphragm through the opening there. And that's also never a positive or good thing. No, Kyle, yeah, you know, Kyle, understood, and thank you for sharing that. Really, it's a matter of that we all, through our DNA, unfortunately, can inherit the good and the bad from our parents, from through the DNA, and yeah, it's tough. And so you have to do all that you can to I would tell you that if you can do things from a natural point of view before you have to go that route of taking medication for a chronic situation there. You know, look into that, please. This term deglutition, this is the term that we use for swallowing, okay? Deglutition. What I'd like to do now is share with you all just a, let's see, okay, there's a short video regarding, yes, I would agree with you with that. That's right, Kyle, that is an important thing as far as to do that, for sure. Let's see if we can't get, oh wait, you know what, I put here, here we go. Yeah, I put this, I just save this here, copy and paste. Here we go. So it's only, we'll only play a portion of this video, but I think you'll appreciate it.
Swallowing, or deglutition, is the process by which food passes from the mouth through the pharynx and into the esophagus. As simple as it might seem to healthy people, swallowing is actually a very complex action that requires an extremely precise coordination with breathing, since both of these processes share the same entrance, the pharynx. Failure to coordinate would result in choking or pulmonary aspiration. Swallowing involves over 20 muscles of the mouth, throat, and esophagus, which are controlled by several cortical areas and by the swallowing centers in the brainstem. The brain communicates with the muscles through several cranial nerves. Swallowing consists of 3 phases. Oral or buccal phase. This is the voluntary part of swallowing. The food is moistened with saliva and chewed, food bolus is formed, and the tongue pushes it to the back of the throat, the pharynx. This process is under neural control of several areas of cerebral cortex, including the motor cortex. Pharyngeal phase starts with stimulation of tactile receptors in the oropharynx by the food bolus. The swallow reflex is initiated and is under involuntary neuromuscular control. The following actions are taken to ensure the passage of food or drink into the esophagus. The tongue blocks the oral cavity to prevent going back to the mouth. The soft palate blocks entry to the nasal cavity. The vocal folds close to protect the airway to the lungs. The larynx is pulled up with the epiglottis flipping over, covering the entry to the trachea. This is the most important step since entry of food or drink into the lungs may potentially be life-threatening. The upper esophageal sphincter opens to allow passages to the esophagus. Esophageal phase. Food bolus is propelled down the esophagus by peristalsis, a wave of muscular contraction that pushes the bolus ahead of it.
Okay, very good. So just give you a little bit there. So you'll see there as far as, so that's what's going on as far as the phases of the movement of material from the oral cavity into the digestive tract. And you're seeing here as far as that voluntary phase, that buccal phase, as far as that's the voluntary portion, and the involuntary smooth muscle action, as well as workings of your nervous system in order to control what's taking place as far as swallowing is concerned. Now you'll see here the stomach. So the stomach receives, oh my gosh. Thank you for sharing that, Dora. That was pretty funny, actually. I mean, I think we've all also done something where we've eaten something and it's actually come up through through your nasal cavity and such and out your nose. That's if you've like laughed while you're eating and such, or talking while you're eating, that kind of stuff can happen. Too funny. So the chyme is what's created within the stomach, and it's the too funny, Norma. You'll see here as far as it's a paste-like substance, right? Because it's a combination of the gastric acids as well as what's gone on as far as that's created the bolus to begin with in the oral cavity, and the mucus and the saliva and the food material and such. You'll see here, let's see, is gastric pits present within lead into the gastric glands, which produce this gastric juice, very, very acidic, okay? Glands in the fundus and body produce most of the gastric juice. And so recall that, and let's take a look here, as far as the, so here we're looking at, so here's the fundus, and here would be the body of the stomach. And I didn't mention that in my video, sorry about that. But I did mention the fundus. I did mention the greater curvature and the lesser curvature, and the cardiac and pyloric regions, as well as their sphincters and the rugae. But the body, so think about that, right? So here's the fundus, the superior aspect of the stomach. The body is here, okay? And then again, we've got both of those regions that I just mentioned. So know that also that the material that's present within the chyme will be through the contractions that are going to take place, because look at the pattern of the musculature of these muscular fibers present within the stomach. So we're going in this direction, in another direction. So we have them contracting in such a ways that you're going to create waves of movement of the chyme back and forth, okay, within the stomach. And eventually, as material starts to leave the stomach, it only leaves in little spurts into the duodenum. Right, this is the duodenum, so the beginning of the small intestine. So that's really what's taking place as far as the stomach is concerned. And let's now look at, here we go. So you'll see here that there are different types of gland cells producing different types of secretions and such, okay? Now, we want you to know that the mucous neck cells, right? This is an acidic mucus, right? Very important, it's thin. You'll see here that there's also parietal and chief cells. Now, the parietal cells, it doesn't, the P and the P, so pepsinogen and parietal, they don't go together. So that's what you have to remember when you're thinking about what's producing what. Know that the parietal cells will produce hydrochloric acid and intrinsic factor. Recall that when we were talking about anemia and such, and we said when there's an anemia, pernicious anemia for issues with B12 absorption, right, and B12 absorption, as far as we need intrinsic factor produced by the stomach, in particular these parietal cells, in order to produce red blood cells, okay? When we don't have B12 present and it's not being absorbed, there's a lack of intrinsic factor, this is a problem, and this will affect decrease in the amount of production of red blood cells, will create an anemia. Okay? Chief cells, think pepsinogen. And pepsinogen is really the first inactive enzyme here that will lead to the production of pepsin, right, which will be involved in protein breakdown, protein digestion, okay? So you'll see here pepsinogen is produced by the chief cells. It's inactive until what? Until it interacts with hydrochloric acid, right? So it's activated to pepsin. This is an important enzyme for protein digestion by hydrochloric acid. So the parietal cells, hydrochloric acid, intrinsic factor, chief cells, pepsinogen becomes pepsin as a result of being activated by hydrochloric acid. And you'll see here then also lipase is also for the chief cells there, but only a very small percentage. Primarily lipases, it's primarily in the duodenum that they're being digested. You'll see here also endocrine and enteroendocrine cells. Recall we talked about paracrines and autocrines, right? So autocrines would release a secretion that would really work on the cells that are secreting it. Paracrines are types of chemicals that are being released by cells in close proximity to the cells that they're going to activate and cause some type of effect. So serotonin, histamine, growth hormone, inhibiting hormone, and gastrin, these are all produced by these enteroendocrine cells, okay? The mucosal barrier protects the stomach. So this very thick bicarbonate-rich layer of mucus is really the key to protect the stomach from digesting itself. When this barrier gets affected by H. pylori, right, it gets destroyed by that in sections, it can lead to ulcerations, okay? And this is a real bad thing because we don't want to have, we would really not choose to have acids being present within the peritoneal cavity that can cause damage to the tissues, right? This can be, that could be very much a medical emergency, okay? The term gastritis is a very, a term that's, you just think of, well, it's inflammation and what's going on within the gastric tract here. Inflammation by anything that breaches the mucosal barrier. So again, you'll see here here's the mucosal layer of the digestive tract, no matter where it is, whether it's the stomach, where it may be, and know that that's the inner layer and that has protective mucus present there. And as we're looking at the stomach here, know that very important that Rugae allows just for expansion of the stomach, but it's protected in that thick bicarbonate layer of mucus that really only, like the Helicobacter pylori, acid-loving type of a bacterium, will just eat away at the lining there, and then can definitely affect and breach the layers of the stomach and cause an ulceration here or also within the duodenum, known as a peptic ulcer. Okay, so gastric and peptic ulcers there. Okay, also NSAIDs don't help anything as far as, so these are your anti-inflammatories and such. They don't really, they contribute to the weakening of the mucosal lining. Let's see here as far as about Rugae. Yeah, the Rugae just allow for the expansion. So when you're looking here, the Rugae, they kind of look kind of funny, right? It's not for absorption. It's not taking place there. No, it's for expansion of the stomach. So the stomach will expand as we take in food substances and such. Okay. When patients go on a diet and limit how much food they take in, that'll help to contribute to the more of the, so that the stomach is not so stretched out per se. Okay. That's important as far as part of dieting is concerned. Let's see here. Okay, as far as, so you look here, as far as these enzymes found on microvilli, it is protected by, the Rugae is protected by this right here, the mucosal barrier, thick bicarbonate-rich layer of mucus. That's what's protecting the mucosa of the stomach in particular, right? It's a thick layer of mucus that's going to protect the stomach from the acids. It's very acidic within the stomach, from actually breaking down the tissues of the stomach itself, okay, the walls of the stomach, okay. You'll see here, let's see, as far as, yeah, so digestion really, as a result of the enzymes from the pancreas, as far as secretions from the liver, all contributing to the chyme that's going to be present within the duodenum will help as far as the enzymatic breakdown of the food material. Okay, you'll see here stomach empties approximately 4 hours or so. If there's a lot of fat present in the food that's been eaten, this will slow down the processing. Okay, just know that there. As far as the different centers present within the nervous system, as far as for the process of emesis, of vomiting and such, that would be in the medulla oblongata. So excessive vomiting can lead to dehydration, we know that, and electrolyte and acid-base imbalances can occur. And so very important, like so Pedialyte for the kids and such, and for adults also, as far as some type of electrolyte solution in order to replace the electrolytes as well as the liquid that's been lost as a result of excessive vomiting. You'll see here, as far as I'm seeing my little granddaughter walking outside there in the yard. It was a nice day out there today, folks, right? Still some sun out there and such. Digestive processes of the stomach. So we'll see here, as far as carries out the breakdown of food, absolutely. A holding area for food, very good. Contributing to actually moving the food distally to the small intestine, in particular to the duodenum. Yeah, understood, Gal. Denaturing of proteins by hydrochloric acid, right? So when we change the actual structure of a protein, we can either apply heat to it. So think about the egg. You put the egg in a frying pan, you apply heat, and then you denature the proteins. Well, also acids can also denature the proteins. Pepsin carries out enzymatic digestion of the proteins there. So that's where protein breakdown begins and digestion begins there. Again, the chief cells are producing the pepsinogen. It's inactive until it interacts with the hydrochloric acid produced by the parietal cells. And then as a result of that, then pepsin is what the active enzyme that's working to digest stomach proteins. You'll see here, as far as lipid soluble alcohol and aspirin absorbed into the blood. And so this can take place very quickly, right? So if you're not eating food and you drink on an empty stomach, can you get drunk? Can you get high very quickly from drinking as a result of an empty stomach? Yeah, most definitely. Yeah. Only stomach function essential to life is secretion of this intrinsic factor for vitamin B12 there, and again via the chief cells and such. So very important. Let's see here. Vagal nerve stimulation increases secretion. As far as sympathetic stimulation will decrease secretion. Again, just knowing that as far as from a autonomic nervous system stimulation for sympathetic or parasympathetic stimulation, that makes sense. Gastrin is a hormone, stimulates enzyme and hydrochloric acid secretion. Okay. You'll see here, as far as, I'm not going to ask this of you to repeat this, okay? You're not going to have to memorize this and such, but just I've put it down here as far as to have a little bit more of an understanding regarding hydrochloric acid formation and what takes place as far as the pumping of, they call it the hydrogen pump, and what we're doing is we're just moving hydrogen ions back and forth through different areas there in order to, with the parietal cells, in order to produce hydrochloric acid. Again, I'm not going to ask this of you, but you can read that there. Gastrin will also, like I said here, as far as stimulating enzymatic and hydrochloric secretion. You'll see here that it also antagonists are secreted by the small intestine. Gastrin released by the stomach increases the motility of the ileum and relaxes the ileocecal valve, which again is that distal portion of the small intestines, bringing the material, that chyme and that mixture into the cecum, the beginning of the large intestines of the colon. Only liquids and small particles are allowed to pass through the pyloric valve. Know that there, as far as in the pyloric region of the stomach. Okay. Chyme is delivered in 3 milliliter, so less than 3 milliliters spurts to the duodenum. Not a whole lot going into the duodenum, little bits at a time, in order for then the secretions from the liver and from the pancreas in order to interact and help to break it down so that we can then have absorption in the small intestines. And really, you'll see here as far as, and it's misspelled here, but force backward into the stomach. So little spurt of the chyme goes out into the duodenum, then we have this movement of this sloshing of this material, this chyme in the stomach, okay? Let's take a look at structure regarding the liver, and then we'll take our break. I think that'll be a good time to take our break. So let's come back to that. Yeah, we'll come back to that. So here we're looking at the liver, and with the liver, folks, in the lab I went over this with you and talked about the different lobes and such. There are 4 lobes, 2 larger lobes, 2 smaller lobes as far as the caudate and the quadrate lobes. You'll see here as far as the gallbladder is concerned. So the gallbladder is going to receive what's being produced by the liver, okay? And that's bile. So bile is one of the secretions that's being produced by the liver, and it's stored in the gallbladder, right, for the time when we have our meals, okay? And so when we have our meals, then the gallbladder will be contracted and will release the bile into the small intestines, into the duodenum particularly, okay? So look here as far as, yeah, so in other words, so what then you're not having really a storage, so you're just going to have, you still will have production of, so know that your liver is still going to be producing bile. You just might have issues as far as with, in particular, fat digestion and such, but your body can pretty much adapt, and it's still producing the bile. It's just not being stored within that gallbladder there. Yeah, you're welcome, Ruth. So you'll see here as far as we have this central vein, and then we have all of these structures here. These are called triads. We have a duct for bile, we have the portal vein, we have the hepatic artery. Now know that for the liver is going to receive oxygenated blood via the hepatic artery, right? And it's also going to receive nutrients and such, as well as blood, from the hepatic portal vein. So that hepatic portal vein, you'll see it right here, right? And I really didn't have a good image, good structure on my models in the lab there, so that's why I didn't ask that of you. But that hepatic portal vein is going to be taking blood from the digestive structures, as far as from small intestines, as far as from the spleen, from the stomach, and it's going to bring the blood first to the liver, and with those nutrients, that's going to help the liver to produce and synthesize proteins and such, as well as these plasma proteins, as well as really just making sure that we're taking as much nutrients as possible to the liver, very important structure, and then going to the inferior vena cava, back up to the heart. So you'll see here that then this central hepatic vein, then we'll take this, all of these, it's bringing the blood to the structures. These hepatic lobules are really analogous to, so when we're looking at the bone, we talked about the osteon, right? The functional unit of compact bone, the osteon. Well, a lobule is the functional unit of the liver. Also, when we think of the urinary system and the kidneys, there's something called the nephron. And the nephron is like the functional unit of the kidneys as far as their ability to filter blood and then produce urine. Well, analogous to the lobule, as far as this is the functional unit, the kidney is full of these lobules, okay? And surrounded by these vessels, highly vascular, and a lot of these hepatocytes present, okay? And you'll see here as far as the central vein and then these different triads, right? Pretty wild. You see how they're all coming together there, folks? Now, what can happen when we have fatty liver is that we're going to have the tissues of the liver being replaced with fat and really pushing aside and affecting the ability for the liver to do its many functions and such. So let's take a look at our notes here, and we'll see as far as liver function, production of bile, right? Bile, when we think of bile, that's represented the green and stored within the gallbladder. It's an emulsifier. So when you take Dawn dish detergent and you put it in a greasy pan, what happens to the fat globules? They become smaller. It helps to break down the fat. It's not a enzyme. Know that it's not an enzyme. So, but it does help to break the fats down into smaller little globules of fat, making it easier for enzymes like lipases, right, in order to break down the fat, right? Helps to, now the liver really filter and process the nutrient-rich blood delivered to it from the hepatic portal vein, okay? Now, what's going to happen with the liver lobules here, the structural and functional unit of the liver? You have these hepatocytes, these liver cells, production of bile, processing of bloodborne nutrients, detoxification, storage of fat-soluble vitamins. This is really, and really understand this also, that glycogen is how we store glucose in the body, right? So glycogen is stored in the liver, and we can break down glycogen via glycogenolysis very quickly in order to allow for glucose to be present within the body very quickly and be used as far as the ability to the need for glucose, as far as, so like in say a sympathetic process where we have this fight or flight response. Well, do you think that the liver is going to be actively involved in glycogenolysis to release, breaking down of the glycogen and releasing the glucose into the body so that it can be used very quickly by the body for emergency purposes? Very important. And you're seeing here as far as the triad, what it's comprised of: an artery, the portal vein, and bile duct. The sinusoids, right? So you saw as far as this image here. So let's look here. Yeah, so you're seeing here as far as here surrounding the central vein, okay, these sinusoids. Leaky capillaries between the hepatic plates. There's macrophages present within. And recall, what did we say macrophages are doing? They're removing debris. They're the cleanup crew of the body, removing debris, processing old red blood cells, erythrocytes, and reusing those substances, so recycling them. Okay. So bile, what is bile comprised of? So we'll stop here at, we'll stop right here at bile and go into we'll stop right here at bile, and then we'll take our break. Yellow-green alkaline solution. There's comprised of salts, bilirubin, a pigment formed from heme, as far as the breakdown of hemoglobin present within the erythrocytes. We'll see here that cholesterol derivatives that function in fat emulsification, like we said there, as far as like the Dawn dish detergent analogy, and absorption present for these bile salts. We recycle them, right? So really the body is very good as far as recycling materials that are present within, so that we don't waste much of anything, okay? 95% are, these salts are recycled. The heme that we're actually processing and getting this pigment from, this bilirubin, this is what leads to the color of your fecal material, your feces, which is quite interesting there. And you'll see here as far as bacteria break down in the intestine to this stercobilin, right? About 95% of these secreted bile salts are recycled, which we said over there before. I don't know why that's there, but all right, we'll just go back. All right, very good. Okay, folks, so let's take a few minutes here, and so you can take a little break. You can watch this video I'm going to post up here. Once the video is done, then we'll resume with the remainder of our presentation today. Okay, so let's go into. All right, so it's an 8-minute video. Once it's done, then we'll move on. So this is on fecal transplants can save lives. So if you need to take a little bathroom break, no problem. Just come back and watch. And you can. I'll post this link to this video also, so that if you do miss it, but it's going to be on our recorded video, so it's all good.
I don't think in 20 years of doing this that I've done one thing that takes sick people and makes them well people nearly as incredibly as this does. You can dispute the ickiness of this, but I don't think anybody can dispute anymore the efficacy of this. The science is clear. It's like a miracle.
Ryan Schneider was a healthy 25-year-old when he developed a mysterious, debilitating condition.
I was being treated for what I now know as chronic pelvic pain. I was seeing urologists for it that were trying to diagnose it, and they thought it was other conditions such as an STD or a UTI, and so they were just prescribing me antibiotic after antibiotic. And I didn't know at the time that how devastating those are on your body. And so what the antibiotics did is kill all of the healthy bacteria, if you will. Every morning I was waking up vomiting before work, and I would still go to work and just feel terrible all day. It basically made my immune system similar to that of somebody who's inflicted with HIV or AIDS or cancer. It was from a stool sample that I finally found out that I had C. diff.
Clostridium difficile, or C. diff, is a bacterium that lives in the colon and can cause a number of severe symptoms, such as diarrhea, fever, weight loss, nausea, and pain. It affects about 500,000 patients a year, and it kills an estimated 15 to 30,000 people annually.
Normally I'm 175 pounds. I weigh about 155 right now. So I've lost a ton of weight in the last year.
Most people with C. diff, which is what Ryan has, the dominant symptom is diarrhea. It's really horrible, horrible diarrhea. They're tired, they lose weight, they're fatigued, they have a bellyache. It can be life-threatening. People can die of this.
None of the medications help with my symptoms. Do you take anything else? I am on Prozac now. I'm seeing a therapist because it's just been really draining having this disease for so long. My appetite's not good. I'm feeling nauseous all the time. I'm having trouble sleeping. I'm anxious.
Many people with Ryan's condition have turned to a unique procedure known as a fecal transplant, which involves taking poop from a healthy donor and inserting it into a patient's colon to recolonize good bacteria into their system.
The population that we're treating this way, this is their last resort. They've been sick for a minimum of 6 months, and this cures them. This classic case that I take care of has an over 90% success rate.
A nonprofit in Massachusetts called Open Biome works with doctors across the country to provide them with screened fecal matter. They're essentially a poop bank.
So we process stool from healthy donors and send it out to hospitals all over the country for use in the medical procedure, fecal microbiota transplantation.
Can you tell us a bit about the process?
We have a 3-step process for becoming a donor. Overall, the pass rate is about 4%. So it's about twice as hard to become a donor as it is to get into Harvard. So you go through a 109-point clinical assessment. If you clear that, and most people don't, then you go on and bring in a stool sample. And if you pass that, then you go in and get a blood draw. Because we invest quite a bit of money and time in finding donors, we pay the donors $40 a sample for every food. We've got to process it within an hour of passage. Once the material is collected, processed, and it sits in our freezer, quarantined for 60 days. So, sort of under medical supervision during the collection process. And then if they pass at the end, then we release the material for use and we'll send it out to clinics.
I think the average is about 150 to 200 grams. The biggest sample I've ever seen is 581 grams, which is just ginormous. Like that almost completely fills one of these containers. So I'm just weighed the sample here and grab one of these filter bags. So this is just pumping the liquid through a filter here.
Do some of the donors have a smell that you recognize?
Some donors I would say are generally stinkier than others, but I wouldn't say they have a trademark smell per se. So it's no longer in that log form. We broke it all up. I'm just using this pipette. We're just transferring the liquid into the bottles. We're ready to freeze these, and that's it. The minimum size is enough to create one treatment, but of course, bigger is always better. We encourage fiber.
We're dealing with life and death issues for patients, and we take that really, really seriously. But we also like to recognize that there's a pretty funny element to what we do as well, and particularly with our donors, get them motivated and engaged. What we've done is we've given kind of an avatar to each donor, and so there's a bunch of poop-related puns like Albus Dumbledore or Ninja Turtle. Scooby-Doo is a good one. It's nice to have a bit of fun.
How did you find out about donating pieces of science?
They had a flyer up that they were passing around. We were kind of standing around laughing about it, and it was saying, $40 for every poop, and I was thinking, like, man, this sounds great.
How do you collect a poop donation?
There's a little, looks like a cooler container. It sits in the toilet bowl with a little kind of rack. So you pretty much just go like you normally would, as long as your aim is all right. It gets in the bowl, and then you just pop a lid on it. That's that. It was really weird at first, especially the first couple samples I turned in. But everyone's so nice without a filter in terms of talking about poop around here that I quickly adjusted to it. So now it's second nature, especially at the end of every week. They tell you, here's how many people you saved this week. I mean, it was something I was doing every day anyway when I help people.
After learning about the success rate of fecal transplants, Ryan is preparing to undergo the procedure.
Did you feel weird about having somebody else's fecal material put into your body?
It was weird at first, but I don't even think about that at all anymore, because the way I feel now is weird. I want to feel back to normal. I don't really care what it takes to get that. I just want to feel normal again.
This is done pretty simply with a colonoscopy. So we flush them out, they get an IV, they get sedated. I take the colonoscope, I drive it to the top of their colon, and then we have syringes that are full of replacement poop, and we literally inject 250 cc's or so of poop. That's about a soda can, somewhere the volume's about 10 ounces of poop. We go all the way to the top, we inject it inside, we take the camera out.
What's success for you? Like, let's say 100%, 80%? Like,
yeah, I mean, if I was just not having diarrhea anymore after the surgery and not having pain anymore, that would be success. To see a negative test for C. diff.
yeah.
So it took us 8 months to treat the first 1,000 patients, and then it took us 4 months to treat the next 1,000 patients. We wouldn't be surprised if, in the next year we're sort of treating, more like 5 or 10,000 patients a year. Our mission is to change the epidemiology of C. diff and really start to make a dent in the overall national mortality of the disease.
This episode is a part of Seeker Stories. To see all the stories we post here, be sure to subscribe.
Okay, so I hope you all found that pretty interesting. I thought that's fascinating. I've shown that to many classes over the years. It's an older video, but really quite fascinating, and quite possibly could some of you maybe be a part of working in some office that might be part of this. I don't know, yeah, it's quite interesting. Nimros. That was a good one. That was good. And you have to and understand too that the people that they're treating, right, know how miserable they are. So any type of way that you can bring a little levity to a situation. I joked around with my patients, absolutely, not inappropriately, but just you joke around a little bit and have some laughs, and that's important as far as what they say, laughter is the best medicine. Yeah, understood, Ruth. Yeah, it is very bad indeed. So, all right, let's go on here and look at the gallbladder and see here as far as, again, we've talked about it's a storage of bile, but how about if we have stones that are present? We'll talk about next week there as far as the urinary system and the calculi that can be present there. So we'll see here is biliary calculi, so these gallstones. Too much cholesterol, issues with too few bile salts that can be present. There's something going on physiologically that there's contributing to this. Sometimes it's just a matter of that it takes many years in order for these to develop. Genetics can play a role in this. See here as far as obstructive jaundice, okay? So blockage can cause bile salts and pigments to build up in the blood, resulting in this jaundice type skin. So I have a friend of mine who's since passed away, who had issues with alcohol and such, and he just ruined his liver. And he ended up, thank you. And I went over to see him one day, and I am telling you, the yellow that I saw within his eyes, in the sclera, the white of your eyes, was so yellow. It looked like I'm looking right now outside at forsythia bushes, like those yellow flowers. That's the yellow that I saw in his eyes. And then his skin had that overall look to it also. It was just, thank you, Kyle. Yeah, it's just terrible indeed. Yeah. Oh, so I got a call coming in. Let me just shut this off. Okay. Probably wanting to sell me another a warranty for my vehicle. Yeah. Another warranty call. So, so the lack of the functioning liver, or not functioning 100%, liver failure can cause jaundice. You'll see here as far as hepatitis, cirrhosis. So these are issues where hepatitis, as a result of different types of viruses, and there are many different types of hepatitis A, C, and such, and different ways that they're transmitted and such, as well as treatment-wise, how they can be affected. You'll see here as far as drug toxicity, wild mushroom poisoning can contribute to inflammation and destructive inflammation of the liver. Cirrhosis, here we have this chronic inflammation as a result of chronic hepatitis, or excuse me, as a result of alcoholism, like I mentioned to you before there. Not good stuff, right? You'll see here, liver transplants are successful, and I have had patients that have had liver transplants, and again too, just like with the heart transplants and the kidney transplants, to see them afterwards, it's miraculous to see how they're able to function and live and have an extension on their lives, which prior to that, with just keeping their old liver and how it was functioning, they were going to transition from this life to the next, for sure. Look at this here. The liver can regenerate to its full size in 6 to 12 months after 80% of its removal. I think that's just fascinating, folks. It really is. Yeah, isn't that crazy? It really is, Norma. And just the ability that the liver has as far as its regenerative ability, it's one of the few organs of the body that can do that kind of a thing. Really, it's to do that much, it's one of the only organs in the body that can do that. Yeah, right? True, Kyle. That's very true. So the pancreas, folks, I don't think that we all, prior to, learning anything regarding your health and about the body and anatomy and physiology, we don't realize the importance of the pancreas. Now, we talked about as far as in the endocrine system, as far as discussing insulin and such, right? Well, and that's the hormone. And so the endocrine system, there's only a small portion of the pancreas that's involved in there, right? At those pancreatic islets. But you'll see here, as far as the majority of the function of the pancreas is the production and secretion of these digestive hormones, as well as bicarbonate to help to neutralize stomach acid. And realize that what's going on is that the chyme is coming out of the stomach via the pyloric region, very acidic, right? Because it's a highly acidic environment necessary for the beginning of protein digestion. So we need to cut that acid and neutralize it more so that the enzymes can do their job and work involved in breaking down, digesting the chyme, and then being able to absorb it in the small intestines. So this pancreatic juice that's being released, right? And you'll see here, water, enzymes, electrolytes, neutralizes the acidic chyme, provides the optimal environment for intestinal and pancreatic enzymes. And so before we move on, let's take a look as far as, I want to look at a couple of images here. Yeah, so let's look here, and then we'll move on to the next two images. Yeah, good. So you're seeing here as far as, so again, cardiac, pyloric region right here, as far as the fundus. So here's the stomach, the chyme enters into the duodenum and little spurts, right? And so you'll see here that, and this image is not showing you the major and minor duodenal papilla, okay? But it's just showing you the pancreatic duct, and it is showing you these little pancreatic islets there for digestion, but primarily it's the cells and the structures for the exocrine function of the stomach, of the digestive system, and in particular of the pancreas, that we're focusing on as far as this pancreatic duct. So here we go. This is a better image here, and you're seeing here that we have this accessory pancreatic duct and this main pancreatic duct. Okay, so here we have the head, the body, the tail of the pancreas. Okay, and so you'll see here at this, you're not seeing it on this image. Let's see if it shows you on this. It does. So you're not seeing the hepatopancreatic ampulla and the area where we're going to have the interaction between the common bile duct right here and the pancreatic duct at this major duodenal papilla. So just like recall from first semester A&P, we talked about minor and major, and I said to you that whenever we're looking at the musculature and different muscles that they're same name, except one is a minor and one is a major, rhomboid minor, rhomboid major, zygomatic minor, zygomatic major. we're thinking of teres minor, teres major. The minor is always what? Superior to the major. So look here, as far as on the papilla is concerned, the minor is superior to the major, right? And so you'll see here, as far as just bringing secretions to the duodenum, and the duodenum roughly about a foot long or so, maybe a little bit less, but that's all it is. And then we have the jejunum and the ileum, as far as the small intestines, very much more larger in size than the duodenum is concerned. And here you're seeing, folks, so let's review this and go over this. So we're looking at right lobe, left lobe. So we're looking at here, as far as the left hepatic duct, the right hepatic duct, forming the common hepatic duct. We have the gallbladder here, we have the cystic duct. So those ducts coming together to form what? The common bile duct. And here you're looking at, as far as this is the hepatopancreatic ampulla, where they come together, right in through in here, sorry. And then you're seeing, as far as then released into the duodenum via the major duodenal papilla, that opening in through in there. You'll see here, as far as enzymes are concerned, so proteases, so pepsin, is pepsin a protease? Absolutely, present in the stomach. So again, we're thinking about inactive pepsinogen, interaction with hydrochloric acid becomes pepsin. That's a stomach protein enzyme. So proteases, amylases, lipases, nucleases. So why do you say nucleases? What's going on with that? Well, remember, folks, that when we're taking in animal and plant cells, these tissues that are comprised of cells, what's in the cells? Well, in the nucleus of the cells, we have nucleic acids. So don't you need those also to be broken down with these enzymes and such? And that's very important. Okay. You'll see here, as far as the proteases are secreted in an inactive form, activated after they reach the duodenum, right? And so again, even these proteases, protein enzymes, proteins are difficult to digest and such, and so they're secreted in their inactive form, and then when they're activated, they become then trypsin. So as we have pepsinogen to pepsin, trypsinogen to trypsin in the small intestines, the duodenum. Cholecystokinin, let's go right here, okay? CCK, right? Also commonly known as CCK, right? Synthesized and secreted in the duodenum, stimulates the secretion of the pancreatic juices. So you see how we're working, all these chemicals are working together in order to stimulate the secretion of further chemicals that will contribute to the breakdown of the food material. Now, the chyme is entering into the small intestines, further breakdown, digestion, absorption taking place in the small intestines, and then we're going to produce feces in the fecal material in the large intestines. All right, so the small intestines, length, and other structural modifications provide huge surface area. So look at this here, folks. Surface area, right, as a result of these different structures present, okay, surface area is increased to about the size of a tennis court within your small intestines, because we have these circular folds, we have these villi, and we have these microvilli that are all involved in increasing the surface area present within the small intestines to allow for as much absorption as possible, so we're not wasting any food material that the body has worked hard in order to get. Okay. You'll see here, as far as we mentioned, this MALT, mucosa-associated lymphoid tissue, right? This is involved in the immune response present within the small intestines and within the digestive tract. Know that it's very important, because really, like the stomach acidity, so part of it, absolutely, it's necessary for the beginning of really protein digestion, but also know this, that very acidic, because most microorganisms cannot survive in a very acidic environment. And that's one of the main factors that's very important so that you don't get sick, right? And the Peyer's patches, they're also these lymphoid nodules present within the digestive tract. And you're seeing here, as far as, these, look at this here, as far as the villus epithelium, right? Know that epithelial tissue is rapidly dividing cells, okay? And so let's look here, as far as you're seeing, so chemotherapy, so think about chemotherapy, and that right now, really sad and just very like hitting home. I have a first cousin who lives in PA, not very far from me, and who I grew up with, who she has stage 4 colon cancer, and really, really very sad and very difficult. And she's just now, past 2 weeks, she's been going through chemotherapy and such, and she has many kids. She has 6 kids, grandchildren, and it's just devastating, folks. So we're hoping and praying that that she'll, thank you, yeah, that she'll respond to the chemotherapy. So now, my mom had suffered from cancer as far as breast and uterine cancer, and so we've been very familiar with chemotherapy, and know that chemotherapy. Sorry, Norma, it's terrible. Chemotherapy really, it's changed a lot over the years. It's gotten better, and also dealing with the side effects has also gotten better as far as the medications that can help with the nausea and such. Yeah, Norma, that is, I'm very sad for you and sorry for you. Cancer is devastating, and I don't know of any family that's really not been affected by cancer at all. So no problem. So chemotherapy, right? Attacks rapidly dividing cells, because that's what cancer is. It's rapidly dividing cells. They're trying to create, you know, these cells will divide and divide and create tumors and be invasive and go to other tissues, metastasize. So if the chemotherapy is focusing on these rapidly dividing cells, what other areas of the body can be affected? Well, the digestive tract has these rapidly dividing cells, these epithelial tissue that are continually being renewed, right? And so it can cause nausea, vomiting, diarrhea. It can affect the skin because there's also epithelial tissue. It can affect the hair. It can affect the nails, right? So yeah, it's nasty stuff. But again, too, even the medication in order to deal with the drugs, these very destructive drugs trying to destroy the cancer, it's better than it was many years ago, for sure. All right, so intestinal juice, right? So secreted in response to distension or irritation, meaning expansion of the lumen of the mucosa or irritation of the mucosa. Major stimulus for production would be the acidic chyme, okay? Slightly alkaline and it's isotonic with the blood plasma. That's what the intestinal juice are. The juices that are present within the intestines and that contribute to further breakdown as well as the absorption that's going to be taking place within. You'll see here 3 to 6 hours in the small intestines to absorb all the nutrients and most of the water. And then the remainder of the water will be reabsorbed in the colon. You'll see here after a meal, segmentation will occur. That's the most common motion of the small intestines. What would you think, right? If digestive processes, parasympathetic is going to be stimulatory and contribute to to digestive processes taking place. Sympathetic innervation is always going to be inhibitory and decrease those responses. See here, so between meals, peristalsis will increase, initiated by a rise in the hormone motilin, right? That's kind of cool, right? So we're going to have this movement taking place. So why don't we call it motilin, right? And what's going to happen is that each wave will start from distal and work towards the previous and push it where? In the outer direction, right? Distal, pushing it distal, completing the trip from the duodenum to the ileum, approximately 2 hours or so. And these are all relative, folks, depending upon the overall health of the patient, as well as what they've taken in as far as their meals. And again, too, if you have a high fat content meal, it's going to take much longer out of all the different organic material that we can take into the body. We already talked about this ileocecal valve present at the junction between the ileum, the distal portion of the small intestines, and the cecum of the large intestines, okay? And this valve here will prevent regurgitation back into the ileum, only going in one direction, okay? The appendix, you recall when I showed you the model in the lab there, I turned the model and we looked at the posterior aspect of it, and you saw that worm-like structure. Well, when you hear the term vermiform appendix, that's also a term that you'll hear, it's worm-like appendix, and that's what kind of it looks like there. Part of the malt of the immune system, it does have a function. Bacterial storehouse capable of recolonizing the gut when necessary, the colon, absolutely. So the appendix does have a function. It's not a vestigial organ per se. No, not at all. And you know what, folks, also your coccyx, your tailbone, right? It's not a vestigial tail, folks. It's just a matter of, it's a structure present at the distal portion of your spine in order to allow for there to be muscular and ligamentous attachment and such. So yeah, so nothing's vestigial per se. So here we're seeing here as far as the colon. So we have here the cecum, where the ileum and the cecum come together at that ileocecal valve. The ascending colon, transverse, descending. And now, let's look here for a moment. I want to just bring you back to, or actually no, because I have a better, sorry. Let's look here. Yeah, let's look here. So take a look at this image here. And this is just showing you as far as the small intestines are concerned. And you're seeing how we have present within, you have these circular folds. You have these villi and microvilli present. And this contributes to the overall surface area of the small intestines. And so here we go. So here's the vermiform appendix. Here we have the ileocecal valve right here. There's the ileum, the distal portion of the small intestines, cecum. So the ascending colon. Now, what do we have here? The right colic flexure. I called it, what did I call it in lab? The hepatic flexure. So both are appropriate terms. That's how I call it, the hepatic flexure. And why would I call it the hepatic flexure? Because the liver is right here, above. So right colic flexure, hepatic flexure, transverse colon, and then we have here, let's bring this down a bit. So we have here, oh, okay, it's just the image there, sorry. Would be then the splenic flexure or the left colic flexure. Then we have the descending colon, sigmoid colon, right? Rectum, anal canal, and the anus, right? The longitudinal bands are these tinea coli, smooth muscle, not soft tissue, smooth muscle, tinea coli. And then these bulges of the large intestine or the colon are the haustrum, haustra, plural. So all of these together, we would say the haustra of the colon or the haustrum singular. And then also the epiploic appendages, these little fatty appendages attached to the tinea coli. And here we're going. Okay, and this is just a little bit of a different image, but you're seeing here as far as that we have here. Also, it's showing you here one of the rectal valves that are present, and these are present in order to, you can pass gas and not have a bowel movement. Okay, they help to keep the fecal material present within your rectum and when you're passing gas. Okay, so that's the colon. Let's move on here in our notes. You'll see here as far as structures are concerned, so those are the rectal valves, I've mentioned those. We have sphincters, and so know with the anus that there is an internal and external sphincters present. One you have no control over, the internal sphincter. The external one you do, anal sphincter, because that's under control, so that when you feel that you have the ability to, even when you start feeling that sensation of, you can go and take care of that and have a bowel movement. Okay. So as far as the appendix is concerned, so we know that that's an appendicitis, right? So usually accompanied by a fever, right? So, and it's an infection. You'll see here acute inflammation of the appendix usually results from a blockage by feces, fecal material, that traps the infectious bacteria present within the appendix, and this can lead to a situation where we can have a ruptured appendix, which could lead to then fecal material within the peritoneal cavity, leading to peritonitis, which is a medical emergency, right? Appendectomy is just the removal. So venous plexuses that are in the anal canal region, they can become inflamed, and if they are, that's called a hemorrhoid. The microbiome, right? So I've heard different numbers regarding this, okay, as far as number-wise and such. And so I've even heard recent numbers as far as more of it's just 1-to-1. I don't know as far as the cells and the microbiome, but I know this, that we can't live without our microbiome, right? We have this it's symbiotic. The better word to use would be mutualistic relationship between them, because we provide them with food, they provide us with the ability to what? To synthesize B complex vitamins and vitamin K for our blood clotting and such. They help to metabolize certain molecules and such, ferment some of the indigestible carbohydrates. We know that without a healthy microbiome, we can be very sick. And that's important to know. And we saw that as far as in that video regarding a patient suffering from a bad C. diff infection where antibiotics weren't working. And they're usually very strong antibiotics and they weren't working. So now, you know, going that route as far as that transplantation, how that can make a difference in someone's life. Amazing. But having this healthy microbiome, they used to say the gut flora, right? But it's really not an appropriate term. It's more, the better term is to talk about it as the microbiome, present within and outside of our bodies and such. Just hear my little granddaughter coming in. Sorry about that, from the outside. Let's see here. Yeah, the relationship between our microbiome and other issues as far as pathologies like our body weight, susceptibility to diseases, and even how we think and our moods and such. Very interesting. You see here, as far as manipulating gut bacteria may become a routine healthcare strategy in the future. Not as yet, right? But it can be, and it seems like it will be. It's very important to address that. You'll see here, as far as the C. diff infection, right? An anaerobic bacterium that many carry in the intestine is the most common cause. And what can occur, folks, is that if this becomes like your healthy immune system can work with these different bacteria that live within us, not an issue. But if it becomes an infection, so when other bacteria are wiped out by antibiotics, C. diff can flourish and cause major inflammation of the colon and a chronic inflammation. These infections are resistant to many antibiotics, like I said, difficult to treat, and so the fecal transplantations can make a difference and such. And so very important just to keep in mind and an open mind regarding new treatments and such. You'll see here, as far as digestive processes taking place in the large intestines, right? So vitamins, really, as far as importance. Absorption of water, electrolytes and such are reclaimed. And the movement of, the propulsion of the feces to the anus for defecation, very important. This term here, mass movement. So slow, powerful peristaltic waves, approximately 3 to 4 times per day. And, you know, depending, and then there's usually one aspect of the day where if you're on a regular basis that you'll have a major bowel movement and alleviation of some of the fecal material within your body. Some other terms that we can look at here, as far as diverticula, are these little herniations of the mucosa. Let's take a look here and just see, as far as so we'll see here on this image. So let's look, this is a good one. So you can see here, as far as these pouchings, right? These are these bulges, these are diverticula, right? And then when they're inflamed, and that's not a good thing, right? Where there's an infection that's taking present. Okay, yeah, so then Ruth, that means that yes, there is these outpouchings, right, are present, and they're very common, and they're usually in, right, the descending and sigmoid colon. Okay, know that there, right, as far as that's the presentation. And what we're seeing as far as then an inflammation, some type of infection taking place within those pockets, then that could be a problem that needs to be treated. And staying away from certain food material can also lead to a decrease in occurrence of diverticulitis. Okay, so irritable bowel syndrome. So it's a functional type of a GI disorder. So there's a recurrent abdominal pain, stool changes. We can go from leading to also mental health issues as far as depression, leading to bloating, flatulence, nausea. The stress of it can be really a major factor contributing to the depression aspect of it, and really can be a major issue as far as affecting someone's life and their ability to live an active life. Defecation, again, as far as, you know, when we think of SLUDD, so salivation, lacrimation, urination, digestion, and what? And defecation. So these are all parasympathetic control. And let's see here. Valsalva's maneuver. I don't know if you've ever heard of this before, but not only do we'll use the Valsalva's maneuver as far as having someone kind of bear down a bit in order to see if that increase in pressure can also affect what goes on as far as any type of issue in the spine is concerned, because that increase in pressure can put pressure upon any type of pinched nerves or any type of herniated discs and can lead to an increase in pressure. So Valsalva's maneuver, and this also can contribute to their ability to alleviate yourself during defecation process. Closing of the glottis, contraction of the diaphragm and abdominal wall muscles can lead to an increase in intra-abdominal pressure. Okay. I don't think I need to really go over what diarrhea and constipation is. And you'll see here as far as hydrolysis, right? So the use of water and chemicals, that can be, these chemicals, these enzymes and such, and can be working together in order to break chemical bonds. That's the act of digestion, right? We're taking macromolecules, breaking them down via digestive processes into smaller molecules in order for them to be absorbed. Absorption, the process of moving substances from the lumen of the gut, right, from that inner lining of the digestive tract into the body. And most nutrients are absorbed before chyme reaches the ileum. Okay, so very important as far as that material that's moving from the duodenum into the ileum. That's where the absorption is taking place. I think this is pretty cool. Newborns double their birth weight in 6 months. An adult diet they can have an adult diet by 2 years and such. All right, folks, very